Well, good morning, everybody in North America. Good afternoon and good evening to the rest of the world. My name is Jaime Ponce. I'm the president of the North America chapter from IFSO, past president of the SNBS, and I have here with me my colleague, Samer Matar. He's the professor of surgery at Baylor College of Medicine in Houston, Texas. He's also a past president of the SNBS, and his acting role with North America chapter, he's the vice president. We're going to have an exciting conversation and talks, learning from what's new and what has happened over the last year in North America. Teresa Lamasters is our current president of the SNBS. She is a bariatric surgeon, works in Des Moines, Iowa. And also I have with me Pierre Garneau. He is a bariatric surgeon in Montreal, Canada. He's the present secretary of CAPS, which is the Canadian Association for Bariatric Physicians and Surgeons. And he's our North America chapter Canadian representative. He's also a member of the executive board of IFSO. So we're going to start with the two presentations. And before that, Samer is going to present the panelists that are going to be available at the end to discuss the presentations. Don't forget to send your questions during the presentations, and we'll collect all those questions and try to answer them. So, Samer?
Yes, thank you. So I'd like to present the panelists, the first panelist we have, and we have a star-studded panel of experts, really. First is Karen Flanders, who we all know is a past president of the Integrated Health at ASMBS. She is a nurse practitioner and program coordinator at the Massachusetts General Hospital in Boston. And she has been working in the field of metabolic and bariatric surgery for over 23 years. So, and there are numerous other accolades and accomplishments she's made. So we're very proud to have her with us. We also have Dr. Eric De Maria, who is past president of the American Society of Metabolic and Bariatric Surgery. He is the current chair of surgery at East Carolina University in Greenville, North Carolina. And we also will be having Dr. Marina Kurian, who is the president-elect of ASMBS. And she is a bariatric surgeon at New York Langone. So we're really looking forward to this session and a very stimulating discussion afterwards.
Thank you. So we're going to start with Teresa first, and then Pierre giving us an update on the United States and Canada. And the exciting thing is that they're going to talk to us also about the both annual meetings. I think there's a lot of new stuff coming up. So Teresa, go first.
Thank you, Drs. Ponce, Matar, and Kurian for inviting me to speak today. I'm excited about the opportunity to give an update on about what ASMBS is doing this year. These are my disclosures. They should not impact my talk today. Today I'm going to be talking about what has ASMBS been doing the past year, give a little highlight about the focused practice designation development with the American Board of Surgery, definitely give a preview about the annual meeting coming up in Las Vegas, and discuss upcoming initiatives. So just a reminder, this is the leadership of the ASMBS. This is the executive committee of the Executive Council, and that includes myself as president, Dr. Kurian as president-elect, Dr. Rogers as secretary-treasurer, and Dr. Kotari as the past president. We're part of an entire governing board, which is called the Executive Council, that makes all oversight and decisions for the ASMBS and includes 15 members in total, including 2 integrated health members. So I will tell you that the ASMBS is an incredibly productive society. And part of that is because the engine that powers the ASMBS is our committees. We have 23 committees and literally hundreds of volunteers who dedicate their time and talent to producing a large amount of resources for our members to use in education, advocacy, research, and professional development. One of our very productive committees is our scientific writing committee, which is the Clinical Issues Committee. This is the committee responsible for writing our publications and guidelines. And as I'm sure many of you know, one of the biggest things to come out recently was the 2022 ASMBS IFSO Indications for Metabolic and Bariatric Surgery. This was a joint effort to update the outdated guidelines from the NIH, and this was published in joint access with both SWORD and obesity surgery in October of 2022. There are actually many different updates on the indications, but these are some of the really big changes that had to do with BMI indications. The metabolic bariatric surgery is recommended for individuals with a BMI greater than 35, regardless of comorbidities, and can be considered in those with a BMI of 30 to 35 if they failed other weight loss attempts. And that we should adjust BMI thresholds for the Asian population because their degree of disease is much heavier at a lower BMI. We really emphasize the safety and efficacy of metabolic bariatric surgery and discuss that it should be considered in appropriately selected children and adolescents. There are actually several other components as well, and I encourage you to read through the document. We received a great deal of press coverage on this area, and not just in the US, but around the world, because IFSO is, of course, a federation of 72 nations or countries, so a great media coverage really around the world on the updated indications, so we could speak as one voice. In the US, we've already had some movement in the insurance industry. We've been meeting with several insurers, including Optum and Cigna and Aetna, and several insurance carriers have already incorporated at least portions of the updated indications into their coverage. Some hospital systems like HCA actually incorporated the full guidelines even prior to the full publication. Centene is pretty exciting. They did a massive expansion following the ASMBS IFSO guidelines and expanded coverage for lower BMI patients, but also added bariatric surgery as a bridge to other procedures like joint replacement, abdominal wall hernia repair, and organ transplantation. So as far as I know, this is the first plan to incorporate the bridge to treatment for other health issues. We have several insurers who incorporated lower BMI indications. Unfortunately, we had a negative response from Blue Shield of California, which also then added that patients had to complete 1 year of being on anti-obesity medication, which is problematic. Cigna expanded low BMI coverage and SADI coverage as well, and they've actually been very supportive in working with us. Another very exciting publication that's come out and is very timely is the literature review on anti-obesity medication use in metabolic bariatric surgery patients. And this came out again from the Clinical Issues Committee. This is very timely. This is obviously a hot topic, and it will be also tied to the theme of the annual meeting coming up. And that was led by Dr. Wes Vosberg. We have several publications that came out recently to help support especially general surgeons covering bariatric surgery call coverage. One of those was the bariatric emergencies for the general surgeon, going over the procedures and common emergencies, and the ASMBS literature review on the prevention, diagnosis, and management of internal hernias following room-wide gastric bypass. Another great literature review came out regarding limb lengths for the room-wide gastric bypass. This is actually literally just in the last week. We also did a survey in conjunction with the NORC Independent Research Group at the University of Chicago, the Obesity in America survey. And this survey was actually funded by the ASMBS Foundation. It was really to assess attitudes of obesity in relation to the COVID-19 pandemic. And what we identified was that COVID-19 did make people more worried than ever about obesity impacting their health. They were starting to draw those connections better. This prompted about 28 million people to consider weight loss methods they hadn't thought about before, which also included surgery. They certainly felt that obesity was as serious a health threat as cancer, and definitely one of the biggest health threats facing our country. But unfortunately, the majority of people still overestimated the results of diet and exercise alone and underestimated the results of metabolic bariatric surgery. So we still have work to do. We received a great deal of press coverage around this survey as well, about COVID getting people's attention around the really serious health impacts of obesity and the risk to life. So we actually have several big things coming out very soon. One of those will be the 2023 ASMBS Compensation and Practice Survey. I actually led this survey more than 10 years ago to give our members better data to help them with negotiations and understanding benchmarks. So this is a survey that's been updated and was condensed, and we had 657 responses, which was great. The data will be presented at the annual meeting and available for our members on the website after that. We also have the ASMBS position statement on OAGB coming out. It's in its final stages of approval and should be published soon. Just as a reminder, OAGB was evaluated by ASMBS back in 2018, but was not approved at that time or endorsed. But in 2022, it was reevaluated in light of new evidence. And at that time, it did join the endorsed procedures list by ASMBS. As far as how much impact this has had, it's really just starting to show up in the US. It certainly doesn't have the popularity in the US as in other countries. This is actually before the endorsement came out. So back in 2020, OAGB was less than 1% of cases performed in the US. We will be presenting updated numbers at the annual meeting for 2021. And we start to see some increase in OAGB, but still is hampered by lack of insurance coverage. So again, a few insurance companies cover OAGB, but it's not yet widely covered. So this really impacts lots of geographic locations. Sorry, I skipped a slide. So as insurance coverage improves for OAGB, I think we'll see a shift in the US. Probably not to the degree it has in other places of the world, but I do think we'll see it increasing. So we also have a lot of work done by our Community and Independent Practice Committee. And so they have been putting out webinars with different practice tips and tricks. And the most recent in that was about how to get started incorporating SADIE-S in your practice. So this is a great webinar. It's available on our website for members as well. The Access to Care Committee is also one of our most critical and productive committees in ASMBS, led by Dr. Mickey Seeger, and co-chairs Renee Hilton, Darren Tischler, and Margaret Inneman, and the liaison is Joe Northrup. They've made great inroads. Obviously, also one of the biggest focus has been pushing acceptance and inclusion of the newest indications for bariatric surgery, but also they worked on expansion for low BMI coverage, SADIE coverage, OAGB coverage. Blue Cross Blue Shield of North Carolina is the first regional plan to have coverage for both OAGB and SADIE-S. We also have a very, very active integrated health group. This is the leadership of the integrated health section of our membership. This is a substantial portion of our membership, and they're very active. They certainly support all the activities of metabolic bariatric surgery in our patients. They have many, many projects going on. This is just a small sampling of the projects they have going on, but they are providing support group leader training. They also recently published the review for fasting for religious purposes after surgery, and they are very active with multiple webinars for giving education and training in multiple different IH disciplines. This is also the first year of our inaugural START program. This is the Surgical Technique and Advanced Robotic Training Program. In our first class, our pilot class, we have 15 fellows, and they get essentially exceptional training in robotic surgery, getting didactic and hands-on training specifically in the area of robotics. This was an area that multiple fellows had given us feedback that they needed education in this area. So this is an exciting way to be able to provide that education. We expect future classes to actually grow in size. This first class will receive their graduation and certificate at the annual meeting in Las Vegas. We have ongoing the Doc Matter Collaborative community. This is really starting to really pick up steam. It's a great place to be able to have a lot of complex discussions, especially clinical discussions, and it's vetted and basically watched to be sure that there are no HIPAA violations or things like that. But a great way that you can basically access experts very quickly on any question that might come up. I also want to give an update on the focus practice designation with the American Board of Surgery. This is something we had worked on for a very long time, actually since 2012, and it was approved back in October of 2019. This is an exam to help demonstrate a unique body of knowledge and skills specifically in the area of metabolic bariatric surgery. The first exam was held April 1st of 2022, and over 100 testees or examinees passed the exam. The second exam was given just very shortly ago, actually in April, and we don't have the results of that yet, but there are approximately 120 people who had registered for that examination. So it's really a great value to our members. How is it a value? Well, it helps really distinguish metabolic bariatric surgery as a specialty unto itself. It is a specific body of knowledge. It's a master of an entire disease process. It's not just a technique. It really helps separate specialists from generalists. This can be very helpful when you're negotiating call schedules, reimbursement, and compensation, and helps balance the power given to the hospitals via the MBSA QIP accreditation. And this can really help people define, are you a general surgeon or are you a metabolic bariatric surgeon? I want to take some time to invite you to our annual meeting in Las Vegas, Nevada, coming up in June, just 2 months away. I'm very excited about this. The 39th annual meeting will be held at the Mandalay Bay Resort and Casino. We have over 333 abstracts that were submitted. The theme of this year's meeting is enhancing outcomes through combined therapies. This is a focus on multimodal therapy and combination therapy, and really espouses to an idea of an oncology model of treatment for chronic disease. So what is an oncology model? Well, it's really looking at an access to the full spectrum of therapy. And think of oftentimes how we treat cancer. A lot of times we're able to treat with a neoadjuvant therapy to help downstage the disease. Then we use surgical therapy, which is the most important for treating the tumor and treating obesity. And then we have adjuvant therapy that we can use in combination with surgery to boost the effects of surgery. Some people have resistant disease or recurrent disease and may need repeat therapy or combination therapy, medications plus surgery, or endoscopy interventions as well. Some people are also going to need reoperative therapy for recurrent disease. I'm also very excited to introduce our Mason keynote lecture speaker this year, who is Dr. David Arterburn. He is a renowned researcher in metabolic bariatric surgery, and he's going to be talking about how can we move the needle on bariatric costs, coverage, and utilization. This is really key to our future and our survival. We're going to have sessions on newer technologies and techniques, specifically around endoscopic suturing or ESG, OAGB, SADS, and robotic surgery. We'll have sessions on personal and practice development, focusing on how to thrive in your practice, leadership development, and becoming a QI champion. We'll talk about managing obesity after surgery and treating resistant obesity. There are many great sessions in this area. We'll also have a session on Global Leaders in Obesity, which is a surgery summit where we can hear from thought leaders in metabolic bariatric surgery from around the world. There'll be debates on controversial issues, and we'll discuss what the future of metabolic bariatric surgery may look like. Of course, we're also going to have sessions on cultural competency, diversity, and inclusion. This is an important part to our sustainability and our growth too as a field. We have a fantastic integrated health program as well planned for the meeting. The keynote speaker will be Dr. Robert Kushner, and he'll be talking about multimodal therapy in the metabolic bariatric surgery program. There are great training sessions for all disciplines of integrated health. There are approaches to supporting patients through complications after bariatric surgery, an assessment-based certificate for advanced practice providers, the CBN review course, and Masters in Behavioral Health, Masters in Nutrition. We have courses for the MBS AQIP coordinators and data reviewers, and again, a focus this year on treatment of resistant obesity. So for future directions, what mountains are we wanting to climb for ASMBS? We have lots of areas to continue to tackle. One of my initiatives as president has been to work on a website redesign. The purpose of this is really twofold. The first purpose is to improve the usability for members. We have fantastic resources for our members, but sometimes they're difficult to find on our website, and many members aren't even aware of the fantastic resources we have. So we need to make improvements on that front. The other piece of this is really into an initiative of approaching the public directly. And so when we did an assessment of current website traffic, identified themselves as patients or potential patients. So we want to develop a patient entry portal to the website with patient-facing materials, which has never been our focus in the past, so this is a change for us. We want to improve our connection with the public and potential patients, as well as non-ASMBS healthcare providers, to expand our reach in helping understand the disease of obesity. This is really tied to a campaign to improve direct-to-consumer marketing, basically, or direct-to-consumer contact, to go to the people who are impacted by this disease. One of my big initiatives was really thinking about how can we move this needle beyond just only 1% of people getting surgical treatment for their obesity and only 3% for medical obesity. I can tell you this has been a top priority for us at ASMBS for a long time, and we've tried many things, but we haven't made a lot of progress. So we need a new approach. We need to understand why people don't come to surgery. We've had a couple surveys now that really point to it's based on fear, myths, misunderstanding, and bias. We really need to focus on obesity as a chronic disease. And when you understand that obesity is really a problem with abnormal physiology that can be changed with metabolic bariatric surgery, it starts to make sense that it's not about willpower. And if there's a problem with physiology, it makes sense that there's a surgery that could improve that physiology. We need to win the hearts and the minds of the public. We've gone to primary care, we've gone to specialists, we've gone to residents and medical students, and those are all good things, but it's not enough. We need to go directly to the public and to the people who are impacted by this disease. I really believe that we need to normalize the concept of obesity as a disease. And again, focusing on it being a problem with physiology, not about willpower and character. We need to improve access to medication use. Why? Some people are afraid of medications. They think maybe it's going to run us out of business. And I'll tell you, no, I don't think so at all. When medications become more widely accepted, it helps normalize it as obesity as a disease. And when there's a disease, it makes sense that there would be medications to treat that disease. And then it also makes sense that there could be surgical treatment for that disease. This actually follows a model very similar to mental health care, where it moved from a very stigmatized disease where it was the patient's fault to understanding it more as a biochemical problem and then having medications to treat that, and then normalizing the conversation around mental health treatment and actually encouraging people to seek treatment for their mental health disease. I think this model also works for obesity. We need to continue to beat the drums about the safety and effectiveness of metabolic bariatric surgery. This is not widely known or accepted outside of our circles. And really, multimodal therapy is the key to long-term treatment of this disease. We have to recognize that we are not curing obesity with surgery. We're treating it with the most powerful tool we have, but it's not cured, and we need to continue to treat it. We have many upcoming projects that I think are very exciting. One of these is the ASMBS International Certificate Exam, and this will be offered for our international members. And it's a knowledge-based exam to help demonstrate again a focus in metabolic bariatric surgery. We'll be announcing more about the exam at the annual meeting and hope to have our first class sit for this in 2024. We also will be producing a statement in response to the push for insurers pushing us to go to same-day discharge and outpatient criteria for all of metabolic bariatric surgery, discussing about safety and priorities for the patient as well. We have a multi-institutional research collaborative, the ARC program led by Demetrios Stefanidis, and they're really working towards starting some of their first big projects, so you'll hear more about that. Again, the compensation survey, the international certificate. We're going to be having a focus coming up on artificial intelligence and how we can leverage this and be a part of this on the front end to help us stay on the forefront of how this can be an advantage to us and not be weaponized against us. We'll have a position statement coming out on ESG. We'll have education curriculums around the newer procedures, including OAGB, SADS, ESG. We continue our access to care work, especially in these areas, and we continue collaboration with partners to overcome the challenges of obesity, and that includes with our medical colleagues, such as with TOS, OMA, OAC, Stop Obesity Alliance. We have a roundtable on obesity so we can all work together and really talk with one voice to have more influence and power over what's going on. There are a few sessions I want to invite you to that I think will be exceptional for our international colleagues. This includes our welcome reception at the annual meeting where you can meet the leaders in global and U.S. metabolic bariatric surgery. There will be an IFSO symposium at ASMBS that will be focused on medical liability in bariatric surgery and how to reduce exposure. And then there's going to be the Global Leaders in Bariatric Surgery Summit, and that will be followed by the international reception. We will be giving 2 awards to our international colleagues who will be recognized for their contribution to the field of metabolic bariatric surgery. This is given a joint award between ASMBS and IFSO, and it's supported by the ASMBS Foundation or the TREO Foundation. So I know it's a lot to digest, but I will say that I am super excited for you to come join us and be involved and connected to this exciting, vibrant community. So thank you for your time. I'm looking forward to the discussion.
Thank you very much, Dr. Ponce and Dr. Matar. At first, I would like to thank IFSO to give me the opportunity to present today at this IFSO North American chapter webinar. And my subject today will be what's new in metabolic and bariatric surgery in Canada. For my presentation today, I don't have any conflict of interest who will interfere with my presentation. For those who don't know, Canada is a country at the northern border of USA. Sometimes we consider Canada the young brother of USA, or sometimes we consider Toronto as a US city. Probably because we won the NBA championship in 2019, or when the Blue Jays won the World Series in 1992 and 1993. But more seriously, one of the big difference between USA and Canada is the healthcare system. The healthcare system in Canada is public since 1966. And when we mean public, that means it's a free medical access to any medical service or any medical surgery. Any surgery. Each province has to manage their own healthcare system. But with the fact that we have a public system, you're not gonna find a lot of private bariatric surgeons in Canada. And as you could imagine, we don't have any insurance company who cover the surgery. we have three objectives today. The first one is to look at some update of CABS. What is CABS? CABS is the Canadian Association of Bariatric Physician and Surgeon. Second objective will be to look at what happened in Canada over the last 2 years, and at last we will look at some highlight for the annual meeting in Toronto. During the pandemic, one of the biggest teamwork from CABS has been the creation of the guideline for Canadian Bariatric Surgical and Medical Center. Those guidelines has been developed with the creation of a standard committee at the beginning, who spent many hours on Zoom and Teams working on consensus statement with a long process, as you could imagine. And after several versions of the draft, CABS member receive one of the latest version for comments. And after that, after receiving those comments, the final version has been created and sent to the Canadian Journal of Surgery and accepted for publication in 2022. One of the main goals of this document is to improve the center of expertise, trying to create a standardization, looking at program requirement for each center. And one of the other goals is trying to implement a national database, because actually in Canada, one of the biggest lack of information for bariatric surgery is the fact that we don't record all the data for bariatric surgery. Yes, some center do it. Some province have a logbook for the type of surgery, but we don't have a formal national bariatric database. And I hope that in the future, with the creation of those guidelines, the national database will come. For the Canadian Bariatric Surgical Center, we decided to have the same type of classification as in trauma surgery. That means level 1, level 2, and level 3 center. The level 1 is the tertiary care hospital, we call it the University Center, with a minimal of 250 cases a year. That was a big debate for the minimal amount of cases, because you could imagine that each university center have its own practice. And we finally, after many discussion, we decide that 250 cases will be the minimal for level 1 center. At least those centers need to offer 2 accepted bariatric surgical procedure and more. A bariatric surgeon should be the director, and at least 2 additional bariatric surgeons should join the team. And we want to make sure that those level 1 center ensure a long-term follow-up. Here we have an example of recommendation of the minimal staffing requirement for level 1 bariatric surgery center. You could imagine any staff for covering cardiologists, respiratory, gastroenterologists, radiologists, and a good gastroenterologist or endoscopic training surgeon who could offer therapeutic endoscopy. For the level 2 center, we require high quality care center, but we don't need a university center. The requirement is a minimum of 100 cases a year with at least 2 bariatric surgeons. And we focus on treatment on lower risk patients. What is a lower risk patient? Any patient younger than 65 years, any patient with a BMI lower than 55 on a man or 60 on a woman, or any patient with ASA lower than 3. A level 3 center is our ambulatory center. We call it a day surgery center. All those centers need to have an agreement with the level 1 to make sure that if any situation or any problem occur, the patient could be transferred to the level 1 center. Any surgeon who work in those day surgery or ambulatory center need to be experienced surgeon with at least 50 cases annually. And we focus as well on a lower risk patient. After the publication of our guideline, the French province of Quebec has been the first province to use totally the guideline to produce their own strategy to create bariatric center and medical center for taking care of obese person. Okay, now let's go and look at what's happening in Canada over the last year. During the pandemic, a national survey has been driven by CAB's president, Dr. Stephen Glazer. That was an online survey looking at 2 samples. The first one was more than 1,000 patients living with overweight and obesity, and the other group was individual recruiting through obesity clinical service. The EPOC survey included 154 questions. One of the first papers coming out from this national survey was looking at the weight gain, weight management, and medical care for individuals with overweight during the COVID-19. If you look at the result of this national survey, we found that during the pandemic, more than 55% of the patient reported weight gain during the pandemic, and mostly on class 3 obesity, the black box. And on the right side, we found that patients enrolled in clinical obesity management gained more weight during that pandemic, and mostly as on the class 3 obesity as well. Another impact has been the healthy eating. We know that during the pandemic, overweight or obese patients had a lot of lack of motivation for healthy eating, lack of routine, mood change, depression, and several other problems during that period. Another interesting finding was the impact of vaccination or the attitude or concern toward the COVID-19 vaccination on overweight and obese patients. As we know, obesity is a risk factor for hospitalization, intensive care unit admission, and mortality from COVID-19. And as you remember, a vaccine has been developed to combat COVID-19, but the acceptances in the population has been very different. You remember probably the anti-vax manifestation, but we have been surprised to find that approximately 40% of those living with obesity were not comfortable receiving a COVID-19 vaccination. And the most surprisingly thing was the fact that the higher weight category had more confidence in the vaccination program. And as you know, those patients strongly need vaccination to protect themselves against the COVID-19. And during that same period of time, during the pandemic, a huge collaboration between Obesity Canada and CABS, we call it a huge collaboration, pop out and came with a Canadian Adult Obesity Clinical Practice Guideline. And the framework of those clinical practice guidelines are totally oriented for healthcare professionals, patients, and policymakers as well. And this is the first comprehensive update in Canadian obesity guidelines since 2007. And it's probably one of the most extensive review of published evidence conducted and obesity word. The clinical practice guideline has been published in the Canadian Medical Association Journal. Those guidelines include 19 chapters. They are open sources, free access, and free download. You could download it on Obesity Canada as a PDF file. And 2 chapters will be revised every 2 years. And you will find in those clinical practice guidelines 80 key recommendations. And if you look at those 80 recommendations, you will see they cover any aspect of the management of obesity, from the lifestyle change, the mental health support, pharmacotherapy, bariatric surgery, and on the right side you have all the category of evidence and strengths of the recommendation. Here, this is the list of those 19 chapters covering everything from epidemiology, the science behind the obesity, the role of mental health, nutrition, pharmacology, surgery. And if you look at the last chapter, it's very interesting. There's a total chapter on obesity management in our indigenous people. As you know, indigenous people are a big part of Canada, and they suffer a lot from obesity problem. And I don't think we offer a good service for those population. And just the fact that our guideline pay attention or focus on this is very wonderful. Here we have an example of the chapter number 12, focusing on bariatric surgery, selection, and pre-op workup. As you will find in those chapters, there are always several key messages for the healthcare provider. You found as well many recommendations in each chapter. And same thing, we have a lot of message for people living with obesity, because one of the concepts behind the Canadian guideline is to make sure that any healthcare specialist could understand the management, but the patient as well. Patient need to understand what's going on. And we try to explain to them the effect on health, quality of life, lifespans, and we try to focus as well on all the stigma related with the weight and the bias relief with obesity concern. And for that reason, I like the next slide, because this is a nice example of type of information we found in the guideline. Because it's like I said, it's not only focused on doctors or healthcare specialists, but we focus on patients. And as a surgeon, we know that when a patient enter in our office, the reason why they are there is because they already had a referral for surgery. And bang, we already started a discussion about the options, surgery, indication, contraindication, and risk. But for a family doctor, it's a little bit different, because you need to start at the beginning. And if you look at the item number 1, first of all, any healthcare specialist or family doctor need to ask the permission to discuss about that. It seems to be weird, but if you need to offer a good management or create a good contact with your patient, you need to be sure that the patient is able to open his mind to the discussion, because there are several aspects they need to be discussed. As you know, we need to discuss about food intake, exercise, lifestyle. And if you want to change all those aspects, you need a good counseling. And at the end, if the patient don't agree to participate, that's not going to work. As you know, the basic aspect of treating obese people is to make sure that they understand the treatment and they accept the treatment. Since the creation of the Canadian practice guideline, it has been very well accepted through the healthcare specialists in Canada. And on the other side, other country, example, the Chilean healthcare already adapt our Canadian obesity guideline in 2022. Same thing for the Irish Health Organization, who launched an adaptation of our Canadian obesity guideline. And finally, what could we expect from our annual meeting in Toronto? As you can imagine, the CABS meeting, it will become soon at the beginning of May, is very smaller than ASMBS, because if you look at the population in Canada, it's 10 times less than USA. That's mean our meeting is more private, and our meeting cover all the aspect of obesity treatment. That's mean we have nutritionists, we have medical doctors, endocrinologists, surgeon, and we try to focus the meeting on 1 day and a half. And the highlight of our 2023 meeting are the fundamental of mini gastric bypass. I will have the chance to present our experience with the mini gastric bypass. One of the biggest sessions will be focuses on the adolescents treatment. As you know, with the new IFSO and ASMBS guideline, I think we will receive more referral for adolescents treatment. And I think in the future, the weight regain will be on the list of our discussion for surgical revision or pharmacotherapy or a mixture of everything together. And another big subject is all the time focusing on the language or the stigma in our practice. I think since the last 5 years, I've seen a lot of evolution on the way we consider our patient, the way we talk with our patient. Another session will be on BMI criteria for non-bariatric surgery. And as like any major meeting, you will find videos, abstract, etc., etc. And I hope that I'm gonna meet you there. Not all of you, but some of you. And merci beaucoup, thank you, and waiting for the question. Thank you.
Well, thank you. Thank you very much, Teresa and Pierre, for this excellent overview and presentation. So now we're going to go to questions, and I'm going to ask the first question, and then we'll let the panelists come up with more questions for our presenters. But Teresa, can you just briefly tell us if international surgeons can join the ASMBS as members, and what does it take for them to be members of the ASMBS?
Sure. So yes, they can join the ASMBS, and in our current bylaws, essentially it defines having them do letters of recommendations from regular members. We actually are reevaluating that for next year to try to make that a little bit easier, because some international members don't know regular members necessarily well enough to get letters of recommendation. So we will be switching to a process that essentially kind of validates that they have a practice in metabolic bariatric surgery in their country and receive some attestations and letters on that regard, and instead of the letters of recommendation. So that will be coming out next year after June. That requires a bylaws change. So we're going to try to make it easier for international colleagues to join ASMBS. But right now, you just go to the website. There's a process. You can join long before we switch that process, using the old process as well, and submit the materials in the membership committee, and then it gets approved and you become a member for ASMBS. So the website will have a part where you can look at join as a member or become a member, and that will explain the details.
And Karen, does that apply also to international integrated health members?
Well, they too can join ASMBS, and we have opportunities for all our different disciplines. It would be nice to collaborate with them on a more collaborative basis for both, IFSO, ASMBS, and Canada, and work together collaboratively for some potential initiatives.
Summer, why don't you ask the panelists the questions that they have?
Eric, what were your thoughts on both Teresa's and Pierre's talks? And did you have any questions or any areas that needed some clarification?
Yeah, thank you, Samer. I want to congratulate both speakers. Really exciting to hear all the things that are being done in North America from both the US and Canadian perspectives. It feels like a really good time to be a bariatric surgeon, doesn't it? With so much good work being done. I did want to just bring up the topic of data collection briefly. Of course, I'm very familiar with MBSA-QIP in the US, and most people around the world are aware of that sort of high quality data collection effort from all the US centers. But I'm embarrassed to admit, Dr. Garneau, I could not remember if Canadian centers are able to participate and contribute their data to MBSA-QIP. So bad on me, but can you comment on that?
Eric, thank you for the question. Since the last few years, any CABS board meeting came with this bad aspect of covering the data, the national data. As you know, this is a problem because with the public system, we have the regulation transfer the responsibility to each province, okay? And each province has to create their own database, but as a public system, we don't have a lot of money. And sometimes the money are not put at the right place, and for that reason, we need somebody going to drive the new concept of creating the national database. And with the fact that we already launched the guideline last year, we hope that the guideline, because in the guideline, creating the national database is part of that, okay? And we hope that each province who accept to collaborate with the guideline will start the database, okay? But it will be hard to have a national database because each province has to control their own healthcare system. This is the biggest issue in Canada.
Well, Pierre, from our point of view, we can help provide a lot of information about the benefits of having a national database that might help, support your cause as you present this to both the local and the national governments. And we can do this for any other country whose members might be watching. I'm sure MBSA-QIP and its leadership will be happy to collaborate with any other entities that might be interested in initiating a national database.
That would be
a quick question or a comment on that too, is that Canadian centers can join MBSA-QIP and become certified and contribute their data that way and get data back. Now, it wouldn't be just for Canada, but there's a potential you could create a Canadian collaboration or kind of like what we do for some states. And then you could get the Canadian data back. So that would take some work with MBSA-QIP to be able to do a carve out for Canadian data to be able to compare yourself to other Canadian centers, because otherwise you'd be compared against all MBSA-QIP centers across the US. So there is a way for Canadian centers to become accredited for MBSA-QIP and then put their data in and get data back, which is at least a start. But there is a potential for collaboration to actually create a Canadian collaborative so you guys can compare against each other too. Now, I'll tell you that new centers who are applying right now from Canada, those are on hold for a little bit because they're redoing their contracting or something, but that should be available within a couple months.
And the other thing is our new certification or designation from the American Board of Surgery, the FBD, that's required to submit data on MBSA-QIP. Is that right, Eric? So is that could be an option for Canadians if they submit data? Are there any possibilities for them to take this test or not?
So that's a great question, Jaime, and it's really a technical question. Unfortunately, or maybe it's not an issue in Canada, you need to be certified by the American Board of Surgery as a surgeon before you have any eligibility to participate in the FPD exam process and get that designation. Now, I was very excited to hear from Teresa about the ACE, the International Certificate from ASMBS, because that's something that ASMBS has been asked about by international members for years. And to actually develop kind of, I'm assuming in the model of the FPD, something for international bariatric surgeons to get certified, I think that's a wonderful advance. And really, I think a good response to the demand from our international colleagues.
Agreed, very exciting. Marina, any thoughts on what you've heard today?
No, both were really fantastic presentations. And, I loved Teresa's detail on all the different projects that are ongoing. And, as Eric just mentioned, that ACE exam was something that, I think Shadow had really kind of started the process, but Teresa was able to get Rana Pullat on that, and really kind of, he fleshed out a lot of things. And it's so exciting that, as we bring that to fruition, it will help, I think, a lot of bariatric surgeons around the world. I had a question for Pierre, though. In the US, Pierre, the penetration of surgery is actually less than 1%. We keep saying it's about 1%. I think it's like 0.6, but whatever, it's low. What is it in Canada? Are you able to measure that and see if your penetration is better? And if it's more than 1%, what do you attribute that to? Is it more of a collaboration between physicians that's driving it, or is it actually patient driven?
Thank you for the question, Marina. Honestly, the penetration in Canada is not better than in the USA. But if you look coast to coast, some provinces have a better access, mostly Quebec and Ontario, because those two provinces has been involved in bariatric surgery since more than 30 years. This is the main reason. More center, more hospital offering surgery, compared to some center in Alberta where they don't offer a lot of bariatric surgery, or even in Vancouver, a major city, limit the amount of bariatric case a year, controlled by the province regulation.
What about medical tourism in between United States and Canada? Can any of you comment on that? On our perspective, one of the biggest issues for surgeons who take care of any American citizen is the lawsuit, because in Canada, we have a public system who cover any lawsuit against patient, against doctors. And the CPMA, the insurance company who cover the surgeon for Canada, don't cover a surgeon who take care of any American patient or any citizen from outside of the world. And the recommendation is to not offer surgery on any American citizen for that reason. Interesting.
But you could do it, Amy, but if you face a lawsuit, the insurance company not going to cover everything around that.
Karen?
Yeah, as many of my colleagues know here, I'm pretty vocal about integrated health and their involvement within the society. And I'm curious what CAPS has for their integrated health. I know IFSO is really changing their structure and regrowing it, and interested in what's going on in Canada and how maybe we can collaborate on some projects moving forward.
Karen, actually, if we look at the next meeting in Toronto for CABS meeting, I think 3/4 of the application are from healthcare provider, okay? And I think healthcare provider are very part of CABS, very involved. There's a lot of session on that. And this is a very huge improvement since the last 10 years. because as you could imagine, CABS has been created by a surgeon. After that, we added the medical doctor, and the third step was to add the healthcare provider. But now they take most of the place, actually.
So another topic, the OAGB, one anastomosis gastric bypass, just recently endorsed by the ASMBS, but in Canada, it's been endorsed and used for years. How many years have you been using it, and what can we learn from Canada and the adoption? What's the percentage of patients that qualify for that, and who are you using it on?
I know, Amy, not much. The few center offer OAGB, okay? And I know there's only one private center in Toronto who offer this procedure. And in Montreal, at our university, we offer the OAGB, but it's not widespread in Canada. And we don't have a huge experience yet, but we will present our experience at the IFSO. Now we're going to send some abstract for the next IFSO meeting in Naples, because I think we did a couple of papers on that subject, but there's not much information from Canada, Amy, about the OAGB.
What about United States, Teresa? When do you expect to get more coverage? I mean, this has been a sporadic coverage, but not widely, isn't it?
Correct. So we actually at least have made some ground. At first, there was really no coverage at all. And so what we see in kind of the insurance area is as we get a few insurers to cover, we can actually use that as leverage with other insurers that they should be covering. And as we have more data in the MBSA QIP database, we can bring that also to those insurers who are a little worried and say, look, we're doing this in the US. It's a safe, endorsed procedure, and it should be covered, just like the other endorsed procedures. So it is kind of a building process, and I think we've gotten a good start. But you're right; I think it's gonna take another 2 or 3 years before you start seeing more wide acceptance and coverage in insurance companies.
So yes, Eric.
Yeah, thanks. I just wanted to ask a follow-up about OAGB, because the procedure that was approved first in the US was the single anastomosis duodenal switch, basically. And one of the reasons I think we got a lot of support after that was approved was really you're talking about doing a loop anastomosis on one side or the other of the pylorus. And the procedures really don't seem all that different when you start thinking about it that way. I'm curious what our speakers think about the OAGB as a revision operation for struggling sleeve patients who have gained weight back, because I think it might ultimately be safer to make an anastomosis to the stomach than to mess around with the duodenum. Teresa,
Yeah.
what do you think?
Yeah, so I think that will help it gain some popularity. In some ways, revisions are harder and easier to get coverage for because they're less defined. And so it's easier to say, I have to be able to decide when I get there what I need to do for this patient. But the problem is a lot of revisions really aren't done for weight regain. It's for complications. And the OAGB doesn't fix some of the complications that need a revision from a sleeve. So in that regard, I don't think it will impact those. The weight regain population potentially, because we're potentially pulling on different metabolic levers or additional metabolic levers to what we did with the sleeve. But most programs I think are going to integrate medicines first. And so, we've had really great success on using medications for people with weight regain and decreased our revision substantially because we'll use medications first and then decide if they're an appropriate candidate for an additional surgical procedure. So I do think that's helpful. And I think you're going to see more centers who don't offer medical therapy doing that because they don't feel like they have a lot of other tools to offer patients who are, very discouraged and frustrated. One of the great advantages of our surgery, though, is we don't see a lot of metabolic disease recurrence, even with weight recurrence. I mean, I just saw a patient, this week in clinic who had regained a lot of weight, most of the 100 pounds back out of 140 pounds weight loss, had terrible diabetes before. Diabetes is still fantastic. A1C under 5. Even though she's regained back most of her weight, her metabolic disease did not recur. And so then we have to really start looking at, are we looking for a number on a scale? Are we looking for metabolic impacts that will affect their shortening their lifespan? So it's a discussion that will be ongoing, and certainly we'll have a lot more comments to be made in the future.
Yeah, I think that's the future. We need to have an algorithm of all this variety of procedures that we're endorsing, or when is the ideal time to use them. Summer?
Yes, one of the, as you know, one of the long-standing drawbacks of what we do is long-term follow-up, especially when we start considering larger operations such as the one in anastomosis gastric bypass, SADI, and duodenal switch, and so on. And I believe strongly that the best way to overcome this is to really bring in other practitioners such as internal medicine and family physicians into the team, so to speak, to help promote patient retention. What are we doing in a global scale, maybe to overcome this and recruit people to help us, or maybe other global societies such as the WHO, WGO, of course, in collaboration with IFSO, and maybe that will help raise our penetration of bariatric surgery on a global level. Pierre?
So do you want to tackle it first, Pierre?
I just want to add some comment about the revision surgery. Actually, in my institute, we were running a study on the rate regain and comparing SADI, OA, GB, and gastric bypass. Okay, and it's very interesting because if you look at the preliminary report or result, that's for sure SADI offer probably the best result after a weight regain, and we've seen that the OAGB looks similar to the SADI as a result. A little bit less complication about malnutrition, but more complication about reflux. And actually, our biggest concern is what is the best procedure to offer after weight regain and reflux? Because as you know, several patients with sleeve gastrectomy will present with reflux, mild, moderate, or severe reflux. And I'm always concerned to offer a SADI procedure on a patient having a lot of reflux. Or can we offer OAGB with a patient with a mild reflux? Because as you know, as soon as you create anastomosis between the stomach and the small bowel, you relieve the pressure inside the stomach. But we're still working on that. We don't have a clear view of an algorithm, but I think in the near future, we're going to be able to create algorithm with what is the best option from the start, from the weight regain, diabetes regain, or reflux as well.
I think we're going to wrap it up. It's already 10 minutes after the hour. I wanted to thank Teresa and Pierre for the great presentations and updates, and invite everybody to attend both of their annual meetings. We have exciting things coming up. So we're here, North America chapter, I think is strong as he has a lot of things going on. Look forward to see all of you also in IFSO and Naples. It's going to be an exciting annual World Congress. So thank you very much to everybody, and look forward. This is going to be recorded, so if anybody wants to see it later on, it's going to be in the IFSO recording website. Thank you.
Thank you.
Thanks,
you all very
guys.
much.
Great to see you all.